So good evening, everyone. Welcome back to our journal club. It has been a week since we discussed about flexor tendon last week, and I believe many of you have come into taking chance to read the journals that has been distributed about 6 days ago. So I think time is good for us to get in touch with the readings. Now it came to my turn to be your reader. To represent you in presenting the three journals that we have. All right, let me just start with this slide. So when you see the slide, I think it's very simple to understand from the presentations of the wound. It comes from a sharp injury during the pandemic in Jakarta. We got quite numbers of incidents which raised up, especially with the robbery. So the criminals were actually going around to get a chance to get their victims and taking money or other advantages from the vehicle, especially with a motorbike. Then if you remember, with this cut, we can consider that deeper part of the structures may also involve in the injury. So the presentation with the X-ray here shows us that nothing happened with the bone, but then it's very obvious to see the cables or rupture. And when we ask the patients to extend the digits and the fingers, you could see very obvious that the three ulnar digits, or including in also the central digit here, and also the two ulnar digits are not able to extend. You see that the extend comes only with the index and also with the thumb. So then it's obvious that this area involving the extensor tendon for the 3 digit here. And if you still remember, then the the zone of injury also give you understanding that with this level of injury, you could see the diagrammatic picture on the right-hand side. It involves what zone? Yes, correct. It comes with zone 6 and also 7. So it's very easy to remember the zone with the extensor, although numbers are quite many, greater than the flexor side. But then zone 1, if you still remember, involved in the area of the joint. The distal interphalangeal joint is the zone 1. So then the odd number comes with the zone 3, zone 5, and also zone 7, also involving the joint. So this is involved the proximal interphalangeal joint. This is the MP joints. This is the wrist. So it's very easy then. The other even number would be in between the joints, zone 2, zone 4, zone 6, and then zone 8 and zone 9. So what's the difference between zone 8 and zone 9 is actually bordered by the musculotendinous juncture. So musculotendinous system is actually comes into the border between the zone 8 and zone 9. So if you have the injury in the zone 9, you realize that it mostly involved with the muscle without any involvement of the tendons. Okay, so what structure involved could be predicted by knowing the system underneath. So basically, understanding the anatomy would come into a better and easier diagnosis of the case. And what about this case? Now you still remember what zone is it? Yes, it's mostly involving zone 1. And it comes with kind of like, slightly crushed injury. It's not really clean cut. And if you see the presentation, when you ask the patients to extend all the joints, then you see the Mallet presentations here. And because of the injury, we also consider that it may involve the bone as well. So if you see the X-ray, then you see here some of the distal or the base, sorry, the head of the middle phalanx actually involved with this avulsion. Now it comes with different presentation of the case. So what zone is it? Still remember? It involves, yes, almost involving the joint with the MP joint. And so, oh, that's too hard, too strong. And so, well, it involves the zone 5. Yes, at the level of the MP joint level. And if you ask the patient to extend the fingers, now you see that the central digit here cannot extend into 0 degree like the other fingers here. So it's quite obvious. So the incidence of the extensor tendon injury is quite high. It's almost 18 per 100,000 population. In regards of the Mallet fingers, it's almost 10 per 100,000 of population. That means it's quite frequent for you to get the patients in your practice, be it in a hospital or in the clinics. Then you are ready to understand the extensor system. In regards of the 3 journals that we distributed for you to read, so we talk or we discuss about the anatomy and also the function of the extensor tendon. You still remember? The first reading was about the biomechanics, back up with the clinical anatomy, and also some of the surgical procedures were reviewed in this reading. So it comes from the 2016 of the publications. But then the remaining 2 came from this year of the publication. This comes with the anatomy from the cadaveric study with the prevalence of the extensor system at the hand part. And also, what do you call, like a study, experimental study in animal. I mean, in the tissue samples, not the animal, the tissue sample from the human, I mean, from the fingers. And comparing the system of surgical technique. All right. Now, the left-hand picture, you actually could recall the flexor system, which is much more easier when you recall the system of the flexor tendon in the digit and also in the palm. And it's only a continuations in the forearm, if you still remember from the last week discussion. Now we come with the extensor system, where basically the extensor system is divided into the profundus group or deep group and also the superficial group. Now you see the superficial group are very easy to remember. They involve the wrist extensor, the extensor carpi radialis brevis and also longus, and then the main extensor tendon for the fingers, extensor digitorum communis, and also extensor tendon for digiti minimi. Yes, and in the superficial group, it also involves the extensor carpi ulnaris. So the wrist, and also this one is for the digit. The deeper group involves the system or the extensor for the thumb. APB, EPB, EPL, and EIP. So this is the only one from the fingers that comes in the deeper system, the extensor indicis proprius. This 3 is actually responsible for the thumb, the abductor pollicis brevis, extensor pollicis brevis, and also extensor pollicis longus. All right? So all the extensor system is actually innervated by the radial nerve. It's very easy to remember just by the radial nerve. Now, again, different presentation with a better colored picture here, the deeper system and also the deep group and also the superficial group. Once again, the superficial group involves the EDC here and also the extensor, what do you call? The digiti minimi and also the extensor carpi ulnaris. They are all in the superficial system. This comes deeper, all right? You get it? So this is the extensor pollicis longus, and this one is actually extensor pollicis brevis, and also that one is abductor pollicis brevis, this one. All right? Okay. So what about the intrinsic muscle? Yeah, it's very important also to consider the intrinsic muscle in discussing the musculotendinous system of the hand that comes in harmonious work all together between the flexor and also the extensor. Now let's get into some review with this intrinsic system. So it's quite nice for me to get this color picture. So this is the intrinsic system in the thinner part. So the flexor pollicis brevis, the abductor pollicis longus, and also the, abductor pollicis brevis, and also the opponens pollicis. All right? Then this one is actually for the hypotenar. The main muscle in the the main muscle in the hypotenar is actually the flexor digiti minimi brevis. And then we have also the abductor digiti minimi. All right. And let me take this one. Yeah, this one is not described here in this picture. The opponens digiti minimi and the opponens digiti, opponens pollicis is not described here. I think the opponens is deeper here. The adductor and also the opponens pollicis is deeper here. I'm supposed to be here, sorry. This is the adductor, ADD, adductor pollicis brevis, and also this is the opponens pollicis. So this three structure is deeper than this superficial part at the outer layer. Oh, I forgot that I need also to describe the lumbricalis muscle and also the interosseous later on, that hopefully I could get the pictures to be shown to you. So the lumbricalis muscle here, there are 4 lumbrical muscles. While for the intrinsic muscle, if you still remember, we have 7 interosseous muscle, 4 at the dorsal and 3 at the volar side. Now, let's bring into the wrist level, which is quite unique of the positions of the extensor tendon, where it does not follow the course like, subsequent from radial to ulnar, specifically with the compartment number 3. The thumb is positioned in the radial part, but then the extensor pollicis longus is actually not in the main radial side. It comes in the 3rd compartment. So this is the wrist level, but then it goes through the tangential cutting of the radial bone and also the ulnar bone here. So this is radius, this is ulnar. So from the radius part, the 1st compartment is filled by the abductor pollicis longus and also the extensor pollicis brevis. If you still remember the Quarvine disease, so it involved these 2 tendons in the 1st compartment. Then the 2nd compartment involves the extensor carpi radialis and also, brevis and longus. So both are actually the extensor for wrist at the radial side. Then the compartment number 3 is filled by the extensor pollicis longus. So, hey everyone, do you still listen to my lecture? Just to make sure, let me hear the voice from Eliza. Oh, okay, I could hear someone. All right, shall I proceed? Okay, so the compartment number 4 is filled by the EDC and the indicis proprius, right? So it's from the 2nd digit to the 4th digit. The 5th digit exists in the compartment number 5 at the ulnar side, and the last one is actually for the ECU. Okay, hopefully that this is only a review back again to realize from the tangential view into the dorsal view. So if you recall back with this radial side, so the first compartment would be for, still remember, the APL and also the EPB, right? I do not think that I need to repeat all the 6 compartments. Just remember, this is the compartment number 3 is filled by the extensor pollicis longus. Then comes with the further descriptions with the extensor. Again, you see that going into distal, the system is not like, you know, straightforward cable like the extensor tendon in the dorsum and also in the wrist, and goes into or go into the more proximal part in the forearm. So the system in the digit is not straightforward like the flexor tendon. It comes with mechanism or system. So we call the extensor tendon as extensor mechanism or system. Now you see, the main extensor is actually this one, the common extensor tendon, or the EDC, extensor digitorum caminis. Common, meaning that, you know, it comes with, you know, one single bundle here, and the muscle is actually mostly all together, combined together in one, what do you call, a tendon, it's not sheet, I forget the name of the structure here. All right. Then the central slip or the main extensor tendon here insert in the middle phalanx. Still remember, it's only stopped here in the middle phalanx, while it trifurcate with the lateral slip. This is the central slip, and then it comes with branches of the radial and the ulnar side with 2 lateral slip. And it will join with the lateral band here that is mainly formed by the intrinsic muscle. So then this comes from the lumbrical muscle and also the interossei muscle, and forming the lateral band and joined together with the lateral slip from the central slip, from the main extensor tendon here, so that it become conjoined lateral band. And it ends up in the proximal, or the base of the distal phalanx becomes the terminal tendon, terminal extensor tendon. So then you realize that this comes from the lumbrical muscle, and the lumbrical muscle and also with the interossei muscle do not only form the lateral band, but also it gives branches to join together with the central slip. So it's quite unique to understand that. Then again, at the MP joint level, we have sagittal band, all right? We will see other part of the structure later on, but then from this dorsal view, it's good to know this is the sagittal band that keeps the central slip, the main extensor tendon here, on its position, because it is held by the 2 sides of the sagittal band. Then it insert, or it's connected, this central slip with the volar plate in the volar side as the floor of the MP joint. All right. So the last one that we could see it from this dorsal view is the triangular ligament. So this triangular ligament is important to keep the positions of this conjoined lateral band in its positions without being able to sublux or to be luxated or slip polarly because of this strength of the triangular ligament. All right, going next with the interossei muscle. So as I have already mentioned, the interossei at the dorsal part, we have 4. Sorry, this one, 4. While at the palmar side, we have 3. So if you look into the volar or the palmar interossei, you see that there is no interossei muscle insert in the central ray or the middle finger. that means it becomes the axial line for this muscle to bring the other digit coming closer. So then the palmar interossei serve as the adductor. All right? Then it's easy then to know that the dorsal interossei works as the abductor of the digit. We do not have the abductor here for the little finger because we have the abductor digiti minimi. If you still remember in the hypotenar bulk of muscles. All right? So the extensor mostly are innervated by the radial nerve, while this interossei muscle are innervated by the ulnar nerve. This is pretty different with the lumbricalis muscle. The lumbrical muscle are innervated not only by the ulnar nerve, but also by the median nerve. Okay? So if you recall the positions of this lumbrical muscle, where it gives the tendon or the fibrous structures to form the lateral band, it basically mainly goes attached into this proximal phalanx. So when it contracts, this is the polar side. Remember, this picture is actually the palmar side. So when it contracts, its function is mainly to flex the MP joint, those two MP joint. And positions of this lumbricalis muscle is on or at the radial side. You see that? The radial side of each of the ray or of the proximal phalanges. And where its origin is at the FDP, the flexor digitorum profundus tendon in the palm here. All right, so now you got the answer already. Now let's go into deeper with the extensor mechanism. I believe you still remember what I have described here with the dorsal view. Now we get the picture here from the lateral side, which is good for you to recall again. This is the central slit, the main extensor tendon, which stops where? You still remember? Here, right, at the base of the middle phalanx, right? Then this central slit is actually kept in central positions by the sagittal band. This sagittal band, you still remember that one, the sagittal band, right? So it connects the central slit with the volar plate. The volar plate is basically the floor of the MP joint at the volar side. Then this is the lateral band, which is comprised by the lumbricalis muscle and also by the interossei muscle, right? The central band gives it branches of fiber into the central slit, and it's formed here going as a lateral band that gives also, that takes also joining fibers from the central slit and then forms the conjoined lateral band, and it stops as the terminal tendon at the base of the distal phalanx. So this is the distal interphalangeal joint. So the lateral band stops here at the base of the distal phalanx, right? Now, beside the sagittal band here, then I would like to tell you about the transverse retinacular ligament here. The transverse retinacular ligament is basically hold the lateral band here into the flexor sheath. So then it prevents the dorsal subluxation of this lateral band going upward dorsally, right? And what about the triangular ligament? You still remember? The function of the triangular ligament is actually keep the lateral band or the conjoined lateral band in its position at the dorsal part, at the dorsal side, and prevents from subluxation polarly. Okay, so the last one that I would like to show you here is the oblique retinacular ligament, which at some point, some people may not consider this as an important structure, but this oblique retinacular ligament or the abbreviation is quite common to be called as ORL, is connecting the volar plate here at the PIP level and the terminal tendons here. So the function of this ORL is to keep the harmony of working or movement of the PIP and the DIP joint. All right. So this is just a recall for the flexor system, which are quite easy to remember, right? And when you compare it with the extensor system, it is much more complex. All right, so what is the quadriga effect? This is quite unique. So just remember, if a patient gets injury in only one digit, then if you do not take care of other digit to advise the patient to move the other digit also suffer from stiffness, from movement limitation. So the reason is because of the existence of the juncture tendinium. So this juncture tendinium is actually taking care of one suffering digit to involve others because it does not move, and also it brings other into limitation of movement, because logically and naturally patient with pain would limit the area that is painful from moving. So then the neighboring digit or fingers would be involved at the suffering stiffness. That's the reason for the what do you call, like stiffness involving other digits that are not involved in the injury. Okay, now I bring you into the normal variation with the extensor indicis proprius, the extensor digitorum communis, the common extensor, the main and extensor tendon for digit, and also the extensor tendon for the little finger. So this one is the study on 43 fetal cadavers with 83 extremities. Now you see, so basically the juncture tendinium comes as type 1 and also type 2 here, but the variations comes at the ulnar part here. The juncture tendinium may comes at type R. It forms like letter R, and this one comes at letter Y. That's quite unique to know this in a system. Okay, do you want me to take a break? Because I cannot take care of the chat box or chat room with these slides, but anyone may interrupt me if you wish. So going back into the cadaveric study here with the fetal extremity or fetal hand. So let me see the chat box here, what happens with people sending chat. Oh, okay, so Rani would like to ask me, would like to ask as a co-host because Elisa was disconnected. Okay, I'll get Rani. So give me a minute. I do not see Rani here. Where are you, Rani? Rani also moving out. Now Elisa comes back. I put her again as co-host. Maybe Prita could learn also to be a co-host. I'll give Prita as the co-host. So when you see people are coming in the waiting room, you just admit them to make sure that they enter the virtual room that we are meeting now. All right. So next, so you see here, the real picture or the real situations comes from the, as a comparison with the diagrammatic picture, type 1, type 2 of the juncture tendinium, and also the type 3 with the Y, and also this one with the R. So it's quite unique. The R comes from that one, R. Oh, sorry. And this one is like simple Y, seeing it from the proximal, not from the distal, like what we see from our side here. Okay, now what is unique that some of the extensor tendon here, let's see, the EDC here, so you count it how many? 1, 2, 3, 4. And this one extensor digitorum communis, this one, 1, 2, 3, 4, right? Okay, so second, third, and this one is actually for ring finger, meaning that the extensor digitorum communis for the digiti minimi comes different or more. So the variation tells us that numbers of the extensor digitorum communis may not only 4 like they are responsible for 4 digit, but it may comes as 5. And what is unique in the ulnar side, the extensor digiti, sorry, the EDC for the little finger may more variation may come as 5 tendon or 5 fibers. All right, I think this is an example of numbers of the extensor digitorum communis, which is more than expected. You know, if we think like, you know, 1, 1, 1, 1, there are 4, and also another one because of the extensor extensor indicis proprius for the index, and also extensor digiti minimi, which is different with the EDC for the 5th finger, right? May come with more, like here, fibers actually many, 1, 2, 3, right? And also this one, 4. So we have 4 extensor digitorum communis in the little finger, right? So this is ED for middle finger, ED for ring finger, and ED again for ring finger. So you do not have to be surprised when you open, there is laceration at the extensor digitorum, extensor tendons at the dorsum of the hand, then you may come with the more number of the fibers. Now here, only for the 2nd finger, it comes with multiple tendons, right? Okay, I think others are just now here. The 5th finger comes with 1, 2, 3, 4, 5. 5, that's quite unique. Extensor digiti minimi, which is different with the EDC for the 5th finger. So this is separated at a different sheet here, which is not, remember, which is not the EDC. So in what compartment this one? Correct. Yes, compartment number 5. Okay, now I bring you into the discussion on the biomechanics of the trauma and also some of the surgical repair, and maybe with some discussion on rehabilitation protocol. But then I would like to take a break just to make sure that all of you are not sleeping. Any of you would like to discuss or to ask questions? Is everybody alive? No video at all? Okay, good to see Prita is fully awake. Shall I continue?
Yes, sure.
Okay, so I'm going to share the screen again, just to make sure that you are all online. I don't want to, laugh by you while you're sleeping in front of your computer. All right, so let's move back into the zones of the extensor system. You still remember that? What I didn't mention is, the zones for the thumb. So it's just the same. With the odd number, it's actually in the joint area, right? Number 1, number 3, it's in the interphalangeal joint, and this one is in the MP joint. Remember, the thumb only has one IP joint, right? And it comes with T4 or zone 4, which is basically as the zone for zone 6. So then they join zone 7, right? So this thumb does not really have the zone 5 and 6. All right. So biomechanics of the trauma relates to the anatomy. So once we realize where the positions of those extensor system and also with definitions of the zones here makes us easy to predict what structures involved underneath the skin or underneath or inside the wound. If let's say we deal with wounding patients. Regarding the imaging that may work for us, of course, X-ray would help you with the identification of any pathology in the bones. But then the ultrasound is really helpful if you deal with the close injury to make sure that you could detect any structure or any fiber or any tendon that is ruptured. Then you could use ultrasound, or you could ask your radiology specialist if you are not familiar with the ultrasound yet, like me. And we could also, for chronic cases, more difficult cases, embark into MRI to just help us with the diagnosis. But then physical examination is still the most. Once you know what structures relate into the anatomy and its position, then you could imagine yourself on how to check with the physical exam. And then the next is about the paradigm shifting in regards of the treatment. So in the past, extensor system, which is basically less powerful than the flexor tendon, when it comes into rupture, then the flexor tendon, the proximal stump would retract directly, straightforward. Then you need to make incision greater to have a proper exposure of the tendon to see the proximal stump. But you still remember the juncture tendinium in the extensor system. At what zone? Do you remember? Right, so in between zone 5 and also zone 6. If one extensor tendon rupture, the proximal stump may not retract too much, and at some point may not retract at all because of the existence of the juncture tendinium to hold or to keep possession of the proximal tendon without necessarily for you to explore it much more proximal like when you deal with the flexor tendon. But then because of the function as the top target for the patient, for any patients suffering from extensor rupture or extensor injury, then the paradigm comes more now into surgical treatment. So the concern on surgical treatment has its greater room, although you actually could realize if you deal with baby or even neonates with the rupture system of the extensor, you may consider the conservative treatment because of the numerous fibers in the system of the tendon, as you have seen it from the cadaveric study. That was quite good study, which was published this year to give us more understanding about the potential conservative treatment for the extensor rupture. All right, going into the technical aspect with the surgery. So many of you, I think most of you still realize that, modified Kessler technique is the easier technique for us because we were taught to use this modified Kessler. Until now, I still practice this modified Kessler suture technique as my main armamentarium in terms of technique to repair the tendon. But if you consider the tendon at the distal part, at the fingers, they are not as, round as the proximal part of the extensor tendon, like the flexor tendon. So the distal part is quite thin. So that's why modified Kessler and many other techniques described here in this diagram may not be easily performed. So then with that distal part, you could actually just do running suture. It's just simple running suture to repair the tendon, which is thin enough at the distal part of the digit. So this is the modified bundle. Bundle is basically using crisscrossing technique, but then with this only, one segment that is being sutured with the principle of the Kessler, but then it's crossing like this, so it becomes modified bundle. It's not Kessler. This is the Becker suture, which is a bit more complicated. You need to practice before you do really, being comfortable with this technique. And you put the not at the outside of the tendon, which is different with the bundle and also the modified Kessler here, which is the knot is inside in between the stump of the tendon, which are being repaired. This one is the running interlocking mattress suture as another alternative for us to repair the tendon. So running concept, but then interlocking. Like if you remember when you suture the fascia in the abdomen, or when you tighten the rectus abdominis muscle, when you perform your abdominoplasty, you may use this running interlocking suture, but then it comes as mattress. All right. I do not think that I would go into the detail with this table because you can, read the journal because the journal is in your hand. But let me just briefly explain what this table describes. This is concerning or explaining the treatment of the extensor tendon injury according to the anatomical site. So with a zone 1, this is just an example. Zone 1 meaning is in the area of the distal interphalangeal joint. So when it ruptures, you know what happens with the presentations of the digit? Mallet Finger is the main presentations with this zone 1 injury. So there are 4 types that people may differentiate the mallet injury or the injury into the extensor tendon at the zone 1. So type 1 is basically closed injury. You do not get any wound. Extension splint is the treatment just by splinting, right? Type 2 of this mallet finger is actually with the open wound, but then without any loss of the tissue. That would include the skin loss and also the tendon loss. So there is no. What you need to do with this open wound, you need to repair it. The running suture with 5/0, with the needle should be round type. Do not use cutting or reverse cutting type because you deal with the fibrous structure, which is very easy to be torn with your sharp needle if you use the cutting or reverse cutting needle. And all of this type 1, 2, 3 is provided also with the splinting, while type 3 is different. Not only you repair the tendon, but also you need to provide soft tissue covering with flaps mostly. Right, type 4 would include the, the injury with the bony loss or the structure loss, and it needs extension splint at the DIP joint or with the key wire. So mostly it involves the intra-articular fracture. It does not necessarily to be always with loss, I correct myself. But then it comes with the greater than 50% of the articular structure or articular surface, all right? So the base of the distal phalangeal bone involves greater than 50% in the intra-articular to involve with fracture or a valse injury. Fragment of the bone involves with the terminal tendon. All right, so you may go on with zone number 2. So this is the concept of the treatment, partial open wound. So this is at the middle phalangeal level, right? Zone 2. If it is less than 50% of the open rupture, you just put splint without necessarily to be ruptured, but you can add with your rupture. So this is quite unique to understand that if the rupture is partial, less than 50%, you can rely on the conservative treatment. But if the rupture is greater than 50%, you just, you just see it the same as complete rupture, because less than 50% of the intact or well-connected structure would not be, strong enough to deal with the strength of the pulling effect when the patient extends the finger, so it may rupture more. So then you need to suture it again with running suture at the zone 2. Or you can use cross-stitch suture. Of course, it's like, making a figure of 8, something like that, with the crisscrossing suture. All right, comes into zone 3 at the level of the PIP joint. If it comes with partial rupture, again, conservative treatment with only splinting. With the partial rupture, you may suture them. You may suture it or combine it with the, you combine it with suture and extension splint or just use extension splint. But for complete rupture, of course, surgical repair is necessary. Zone 4 at the proximal phalangeal level, almost the same, the principle. If the rupture involves less than 50%, you could rely solely on the conservative treatment, but then you can combine it also with surgical repair. If it is more than 50% or complete, just the same, right? But starting from this zone 4, you start using bigger suture material with 4O instead of 5O, with non-absorbable material like nylon or polypropylene, or with other materials, you are also welcome. Right, so zone number 5 at the MP joint level. Now it's quite complicated, more complicated to realize, but let's see. Extensor cuff with the radial sagittal band rupture without tendon subluxation, then you could use conservative treatment. Why you need to consider the tendon subluxation? You still remember? What structure maintained the position of the central slip in its position to be central? Correct, the sagittal band. So when sagittal band is involved in the rupture, but the central slip does not shift into contralateral side, then you will rely, or you could rely on the conservative treatment. So next, extensor cuff radial sagittal band rupture. This is at the radial side. With tendon subluxation, you need to consider surgical repair. In the past, people rely only on splint. But now you actually need to consider repair because of the obvious subluxation. With a partial open clean rupture, you can suture it and or combine it with conservative treatment. Of course, in my understanding, always put the digit or the fingers in the splint. All right. So with a partial open and contaminated rupture, you need to debride and also put it in an extension splint without necessarily to repair it right away because of the dirty wound. So you may consider of the reconstruction later on. Complete open clean tendon rupture, you just repair it. Now at this zone 5, you can consider greater suture material into 3O. Then you may also use 4O, but if you want to use cross stitch, then you can use still 5O, like the more distal part of the extensor tendon, Complete open contaminated rupture, you debride it, and if it comes with a good debridement or proper debridement, then you can repair the tendon straight away in the emergency or at the early possible. Not always in the emergency, you can delay it the next day or the first week. All right, still remember zone 6? Yes, at the dorsum of the hand. When it comes with complete open rupture, you just use a core suture. Now you need to consider core suture, meaning that at the zone 6, the volume of the tendon is much more greater than the more distal tendon. So then you could use the modified Kessler or with the Bunnell technique repair. Then you add it with cross-stitch suture to add strength. Or in my practice, I will still apply it with the concept for flexor tendon by running suture technique at the peritendinal structures at the periphery of the repair site, or the anastomose tendon, or what do you call the meeting point of the two stumps. Complete closed chronic rupture, you may consider tendon transfer because this is much more complicated, right? And also you may consider tendon graft because it comes as chronic. Then, you know, it's not obvious for you to just cut the poor quality of the tissue. Then you may end up with gap. Then you may consider graft. Or you can just apply the principle of tendon transfer later on at the more advanced discussion. With the zone 7, still remember where zone 7 is? Once again, odd number. Odd number is at the joint level, right? Yes, this is at the wrist level. Complete open rupture at this wrist level, you need to consider to use much more greater suture material. You can use 2O, or in my practice, I still rely on 3O. Then try to combine it with cross stitch or running suture with 5O at the periphery of the repair site. With the extensor retinal column, you can provide reconstructions, right? Or if you do not get any tissue loss with the extensor retinal column, you just repair it directly. Complete closed chronic rupture, all right, forget it. You do not need to repair it directly, but then you need to consider tendon graft or tendon transfer. Zone 8, you should remember, it is at the tendon and also the musculotendinous level. If the quality of the tissue is good, you can repair directly. But still remember, when you repair muscle, use mattress concept of suturing technique. If it comes with poor tissue quality, then you may suture the tendon with the muscle side to side. But then if you get some gap, then you may consider tendon transfer, meaning that the distal stem of the tendon could be repaired into the neighboring tendons. For example, if you deal with the extensor digitorum communis, then you do not need to repair it directly, but then you stitch it into the neighboring tendon. With zone 9, you just use the mattress concept, or with this, suggestion by Doyle, you may use figure of 8 suturing technique for the muscle. Otherwise, because if you just suture it with, a simple suture technique, the stitching material, the suture will just, tear the muscle structure. So it is always with the concept of mattress. Can I just take a break to allow you to get some, time to ask questions or anything you would like to disagree? If you have any disagreement or different opinion with what I have presented based on the journals? No? Hi, Newman. Good to see you.
Presentasi luar biasa tadi.
Yeah.
Oh, thank you. Yeah, sorry that I presented in English. So if there is no question, shall I continue?
So maybe I just one question, Dr. Teddy. The tendon transfer on the zone 7. So
right.
which tendon that we transfer to that side?
Right. So because this is not really the advanced discussion. So for example, if I got rupture of the extensor digitorum communis for index, then it comes with poor tissue quality or comes as a chronic case, then I don't need to repair the tendon because it comes with gap. You need to excise the poor quality of the tendon or the tissue. Then I just stitch it into the neighboring, let's say with the EDC for middle finger, or if 2 EDC of second and third or middle finger or rupture, then I just stitch it into the fourth finger. This is an example of just neighboring fibers to be the one to be stitched, meaning that once you extend, then those fingers would extend together.
Yeah.
Right.
So there is no role for tendon graft, on the extensor.
No, of course you can provide tendon graft. So if you're willing, then you could take let's say palmaris longus tendon But remember, in my experience, there are plenty chances, or great chances for you to have poor quality of palmaris longus tendon, because palmaris longus tendon is too thin for me to repair much greater volume of the extensor tendon. It at that zone 7, it's already been big, while the palmaris longus comes with quite thin and small. If you want, then you may double it as like, you know, like double fibula. Yeah, you flip it with a certain length, and then you could use it as a graft. Okay, shall I continue now?
Okay,
Yeah,
please.
then we can come up with a discussion again. I understand, and when I just realized when I prepared this presentation with that, with those 3 journals, I guess I need quite, you know, long time to present it. Otherwise, you do not really understand the concept of this extensor mechanism easily, because you need to read. As I understand, not many of you were reading the journal, so that's why I came with this. I could sense it from your response when I give stimulations. I mean, you know, burning question at the WhatsApp group, that people did not really respond. Okay, I need to prepare it in a more detailed technique. All right, this is the last part. It's going to be very simple. This comes from a cadaveric study on biomechanics about the techniques in repairing the tendon at zone 3. Still remember where zone 3 is? Good. It's in the PIP level. So it's a cadaveric study on 35 randomized finger. The techniques involves the, let me just to remind myself, this is the modified Kessler. This is the double modified Kessler. This is the modified Kessler with epitendinous repair or suture. This is the double modified Kessler with epitendinous repair. And this one is with the more complex repair with mattress concept. This comes as mattress. This comes as interlocking. I forgot the R, but if you allow me, I could see the paper just for a few minutes. Oh, I cannot stop the. Okay, let me just go into the next slide. Then we could see what it stands for. So the parameters of the study in terms of the biomechanics, the authors measure the ultimate load to value, meaning how big the force of the tendon to start to break. Then the shortening effect of the technique, of the suturing technique, the gap formation, once it starts to be, you know, given force to be distracted, and also the parameters to measure the stiffness of the tendon. All right, so this is with the modified Kessler technique. That one is the double modified Kessler, meaning that, you know, the core suture is not only 2, but then it comes as 4. 4 core suture, 1, 2, 3, 4, right? This is the simple one that we commonly use with only 2 core suture. That one is the modified Kessler with the epitendinous repair, as I described. This is mostly what we do for flexor tendon. And also we can apply this technique at zone 6 or proximal. But for this zone 3, the authors also applied this modified Kessler with epitendinous repair. Of course, I do not think that they would use 3.0, rather they would use 4.0. Then this one is double modified Kessler combined with the epitendinous repair as the common technique. This one is more common in our practice. Then this one, the RIHM or the repair that stands for running interlocking horizontal mattress. Running and interlocking and using the concept of horizontal, not the vertical mattress. This one is horizontal, right? Okay, and it ends up with main issue. You may forget the other outcome of the study, that this technique is actually comes with the best in terms of the ultimate load and also the stiffness. But once again, remember, this is only in the cadaveric study, not in the living human. But it is good for us to consider that this technique comes with multi-core suturing technique. You see that? 1, 2, 3, 4, 5, 6, right? 6 core suture. In my understanding, with whatever techniques for repairing the tendon, in the in vivo study, not in the real patient, the more core sutures that you put into your repairing technique, the greater the strength to hold, meaning that the greater the strength to hold, from breaking, from gapping. So that's applied for all of the surgical technique. I think that's all. I'm sorry that I was taking quite long to present this reading, but then it would be good for us to take 10 minutes for discussion before we start seeing video. I believe Elisa has prepared some video for us. Yes, please. Do you have any questions or opinion? Let me ask Beatrix in Samarinda. Did I present it too fast, Beatrix?
No, doctor.
Okay, good. Thank
No,
you.
not too fast.
Not too complicated, right? A bit.
Yes.
It's going to be much easier if you read the readings. The problem is you did not read the readings. Any questions? Come on, do you have any more questions?
Doc,
Okay, now
actually,
yes, please.
I would like to ask before the video. Well, what kind of examinations other than physical examinations, such as MRI, that we need to provide with the patients? I mean, when to ask the patients to do an MRI for extensor tendons injuries? Do we need
Excellent.
to?
Yes, excellent. So if you get chronic case and closed wound, or meaning that you do not see a patient with an open wound, then you can only predict with the story or the history that comes from months ago, then you may be difficult to be sure with your existing structures under the skin. So that's may come into an indication for us to send the patient for MRI. So that you could get a better planning or plans to do the reconstructive technique. Of course, as I already wrote in the slide, I mean, what I presented was we still rely on the physical examination because we understand the anatomy, we understand the function, the biomechanics, then we could check the function of the fingers of the digit, and then we could get a working diagnosis. Then that working diagnosis would need to be combined, if you would like, then if you keen enough to learn about ultrasound, you use ultrasound. But if the ultrasound does not give you a clear information, then you may get the indications to send the patient for MRI. It is much more clearer when it comes with combined, deformities based on the pathology in the bone, and more complicated with also nerve problem. Then MRI would be good for you to help you with your surgical plan.
I see, doctor. Thank you. Yes, because sometimes when to use an MRI, because sometimes some surgeons do some MRIs for adding another examinations.
Yes. Rita, do you want to add more, because you also read the 3 journals, whether I miss important informations?
Can you hear me now, doctor?
Yes, you're ready to sing now.
No. I think I have. You have this three journals could not be described any better than you, doctor.
Come on.
So actually, I have three questions, if you don't mind. One is about the quadriga effect. So once we overcome the main problem, do the other problem will be resolved by hand therapy, or should we concern more? And second, about the anatomy things, could you explain a bit more about the subluxation? Because I find it a bit harder to understand about the ligaments and which part will turn, or they going to which side. And the third, shall I start the diagnostic from ultrasound, or can I just jump into the MRI?
Okay, right, thank you.
Okay.
So those three are excellent questions. The third one, would you jump into MRI? You don't need to. Once you consider that, I do not really understand what I believe under the skin, the remaining structure, or what structures that are in pathology. Let's say if it comes with trauma, what structure actually involved with the trauma? Whether only the tendon or other. Or it becomes with, complicated addition, then you do not really get the explanations on the disturbance in terms of the functions from checking the functions or the movement of the fingers. Then you may come with MRI. But if you think that you are good enough with your ultrasound, or you have, counterpart with the radiologists who keen to help you with the ultrasound, and his or her expertise is quite, good or trustable, then you may rely on his findings through the ultrasound. But if you are not certain, MRI would be good for you to help you. I jump into the question number one. Was that about?
Quadriga effect?
Quadriga. So what we do, I get it simple. Remember, the healthy digit would suffer if you do not move them since the very beginning. Make sure that you know what to do with the involved digit after repair. Then you need limit them from the motion, but the other digit needs to be moved. Or an extreme example, during the pandemics, there are numbers of patients, not plenty, sorry, there are a number of patients who might need to delay the definitive repair. So what I could suggest to my resident, make sure you move the joint, you move the healthy fingers, the healthy digit. Make sure that the patient knows how to move. If they do not move the healthy digit, they will suffer from stiffness. So you still remember my formula?
Yes, three times plus one bonus.
Right. So like taking medicine 3 times a day and bonus at night. But then for every session, every single joint needs to be moved 20 times. So I got it from Sky. Do not ask me the reason. My principle is just to move it as much as possible. If I rely the physiotherapist, you know how many times they will visit the physiotherapist? In our country, I'm not talking about the developed countries. They would visit only half an hour. Some of the physiotherapists will visit and then give them, assistance for 20 minutes. They come twice a week, or sometimes once a week, or even longer. So you will end up with. Question number 2. The biomechanics of the fibrostructure is just simple. You remember the lateral band, for example, right? Central slip and lateral slip. The central slip gives trifurcation before reaching up the insertion, which is in the base of the phalanx. You remember? And that lateral slip joined together with the lateral band. The lateral band conjoined with the lateral slip. The lateral slip comes from the central slip. The lateral band comes mainly from the intrinsic muscle, the lumbrical muscle, and also with the Interosseous muscle. Goes to form the distal part as terminal extensor tendon. So when, for example, the triangular, band, the triangular band is actually in the mid-phalanx at the dorsal part. It holds the lateral band, the conjoined lateral band, in its position. When it extends, and this triangular band is in, what happens? That conjoined lateral band would move polarly, and it would create more extension to the DIP. So then the DIP would be in the hyperextension. So that's why I needed to describe what the function of the sagittal band, the transfer reticular ligament, that triangular band, and also the ORL, the oblique reticular ligament. Because knowing the anatomy and the function, then it gives you what biomechanical explanation if they are incompetent. So then you could describe it in burn injury, for example. Then you could use this concept for rheumatoid arthritis. For example, you remember geriatric people with rheumatoid arthritis comes with deviations of the digit, like all the fingers swift ulnarly. In what level? The MP joint level. Now you realize, if you see that the central slip also deviates, that is incompetence of sagittal band, for example, because the function of sagittal band is to keep the central slip in its central position. But of course, with this rheumatoid arthritis, you cannot rely only with this concept of extensor mechanism, but also with the joint disturbance because of the incongruent articular surface. So it end up with deformities. So it's combined understanding. But then this anatomical understanding with this biomechanics of extensor mechanism would provide us with a good point to describe what pathology you see in clinical setting. Did I answer your questions, Prita?
Yes, doctor. Thank you.
Well, thank you. So guys, you don't need to be worried because this is recorded, and then you can see it again later on demand. Let us just the remaining 7 minutes with video, just for us to keep our promise that any journal club would be also combined with video for the sake of the clinical interest. Elisa, would you?
Yes, doctor.
Yes, please.
I will try to share screen. Wait. How the why it's recording? Start broadcast. Oopsie. No. Wait. I'm sharing screen, right? Wait.
Yes. Just try again.
Okay.
On the digit, and then try to address some issues
Okay,
with
is
return to
everybody
play,
can see?
which of course we can't be totally in detail with that because it's pretty complicated.
So we just stop for
When
a
you look at
while.
the anatomy of the extensors, you have to consider
Wait, okay.
So the position is actually,
Is everybody can see?
yeah, position is perpendicular.
Oh, sorry. Then,
Yeah, you need to,
okay.
no, right. Oh, going back.
Okay, this one.
Yes, okay.
Oh, sorry, sir. Okay.
No,
or remember that you have your contribution from the extrinsic extensor.
no.
No, it's, wait. Share out audio, yes.
Mhm.
Tendons and also the
It's play,
intrinsics
okay.
are contributing. And then you have these very unique special anatomical components that come together to form.
My cell phone, it's
Put it in the landscape.
horizontally.
Okay, then put it in the back into the photos, not in the landscape.
Okay.
Yes, good.
The
Yes.
extensor mechanism,
Okay.
starting proximally with the sagittal band, you have your transverse fibers, the lateral bands, central slip, the transverse retinacular ligament, triangular ligament, the oblique retinacular ligament, and then of course the terminal tendon insertion. On this picture here, you can see the tendons coming in proximally, and then you have your intrinsics, your interossei that are dorsal to the deep transverse intermetacarpal ligament, and on the volar side, you have your lumbricals. And then heading distally, we have our sagittal band, and then just distal to that is the transverse
Elisa,
fibers. If you follow the
Yes.
intrinsics on down through the
stop this video because this is just a repetition
Okay.
of the anatomy. Better to find
Oh, okay.
maybe the one from
So,
Don
okay.
or the Mallet, the second one. Not
Oh,
from the Don.
the,
Yes.
yes,
Yes.
the
Anyway.
Douglas.
Right.
Yep.
Being a good soldier, I have to put Gary's Apples mnemonic in my talk, so he'll think nice of me this year. I think that's a good way to keep the big picture in mind. Basically, I'm going to talk about 3 extensor tendon injuries: mallet fingers, boutonnieres, and swan necks. And the thing about these injuries is none of them are career-threatening, probably, and most of them will end up with a certain degree of deformity that usually does not significantly impact play. The great majority of these are non-operative treatment. And in terms of stakeholders, just remember that the player is still the most important of all the components and all the moving parts. So from Dr. Smith's anatomy lesson years ago, just remember most of these deformities arise because the lateral band doesn't stay where it's supposed to be. So the central slip, lateral band, transverse retinacular ligament, and the triangular ligaments are kind of the key players that end up leading to the deformity we're trying to figure out how to treat. We'll start with a mallet finger. Again, it's the most common closed tendon injury in athletes and non-athletes for that matter in the hand. It happens when there's forced flexion during active DIP extension, tearing the terminal tendon from the dorsal base of the distal phalanx. There are a couple of types to think about. Obviously, either the non-bony component, the pure soft tissue component, or the type 4 is the bony avulsions that can be a small, tiny speck to a significant portion of the articular surface. And again, when the articular component approaches 50% of the joint, we start worrying about palmar subluxation and the need to fix those. Certainly, the great majority of these mallets, not only are they treated non-operatively, but non-compliance, at least with my athletes, is usually the rule and not the exception. They lose their splints, they can't find them, they get sweaty and dirty, they throw them away. So it's hard to keep a mallet splint on a football player for more than about 5 seconds. So really, and the only ones that I'll even think about operating on are the ones that have a significant bony component and there's obvious palmar subluxation on the lateral view. Everybody else gets a splint. The one thing I've found out about splints is, you have a big swollen finger and it hurts and the therapists are putting the splint on. I always take a fluoroscopic view after the splint's placed just to make sure they're not splinting them in 20 degrees of flexion to start off with. So it's
Lisa, would you put it back
easier
into focus?
said than done. So get a
sorry.
fluoroscope after the splint's been placed. Again, you know, with the football guys mostly and the hockey folks we have now in Nashville, ideally you want the PIP joint free. I'm not here to plug kinesio tape, but I think it does maybe provide a little bit more support in combination with a splint. To some of the guys, I can get them to at least keep something on their finger. Again, nobody's going to miss time, I dare say, in any sport for an acute mallet finger. Tape them, splint them, and get them back out there. Again, the only ones that I'll even think about fixing luxation, and again, hopefully that piece is big enough. Player, I'll let them play in a cast in a couple of weeks, and again, if they end up needing surgery, you can certainly put this off until the bye week comes up and then fix them Sunday morning after the Saturday night game. Moving on to swan neck deformities, I see those primarily in two situations, and they're both chronic situations. I've had a handful of basketball players over the years that have had recurrent PIP dislocations. They have a significant laxity in their volar plate. The terminal tendon ruptures and will stretch out and migrates dorsal to the normal joint axis. Again, the great majority of these are going to be treated non-operatively. This splint's not quite as onerous as the mallet splint. You can take care of the skin a little bit better. But again, try to leave the DIP as free as possible. The only ones that I end up fixing in terms of the swan neck deformities are usually the ones that have recurrent significant PIP instability from, a lack of a volar plate. If the volar plate's there but just torn, I'll fix it. If I need to do an FDS tenodesis, I'll take a slip of the FDS. For the chronic mallets that are painful, I'll try to talk them into fusing that joint. I have done a few central slip tenotomies, not in athletes, and I'm proud to say that none of my residents or fellows have ever seen me repair a spiral oblique retinacular ligament in 25 years. So soft tissue, extensor mechanism injuries. Most of these quote-unquote jammed fingers, I'm on the sidelines a lot. They don't come up to me during the game and show me that they're jammed fingers. You know, they don't usually show me the first training session. It's week 2, 3, 4, 5, 6 weeks later when it's still swollen and now it's not bending very lap. But it's a hyperflexed injury. It's common in football and basketball. So in this case, the central slip is disrupted along with usually the triangular ligament. And if the triangular ligament is in fact disrupted, then that means the lateral bands are now free to migrate palmar to the axis of the joint.
Okay, Elisa. Elisa.
Don't get this confused with basically a PI.
Yes, I think it would be much more interesting for the audience to have the surgical technique, but then it's good.
Fracture. The difference with the flex.
Wait.
Yeah.
Yes, sir.
Yeah. But it was good to see some of the examples on the conservative treatment. But maybe next time we would prepare again back more into surgical technique that comes with more interesting video to view together. Because after we get into the readings, then we see the relevance in the clinical setting with the case of surgery. But that one was good, that some of us may get the message with the importance on the conservative treatment already, with again re-explanations of the biomechanical, what do you call it? So sorry, explanations for those injury. All right, so thank you very much, Eliza. If you have still any questions, then we could extend a bit because we delay for 8 minutes. We are not exceeding 90 minutes as the habits or the practice of our journal club. We still have 4 minutes left if you wish to discuss more. Any of you? Melina? Huntal? Made? Dr. Sari, Dr. Odi? Vera?
Yes, Dad.
Any questions?
Pusing.
Sorry. Umu, berbeda umu. Ya, dulu. Well, Dr. Odi.
Ribet ya. Ribet ilmunya.
Iya, ilmunya ribet itu.
Pokoknya jahit aja matras udah.
Oh, apalagi apa? Mata juga udah begini.
Loop lah. Pakai loop dong.
Iya, udah pakai loop. Tenang aja.
Tapi
So,
untuk
ya. Gimana, Dokter Nyoman?
Untuk running epitendon running suture-nya saya sih enggak pernah di extensor pakai 5-0, selalu 6-0. Cuman mungkin karena saya dapatnya tidak sampai di proksimal dari brace ya. Jadi untuk MP itu semua saya juga masih pakai 6-0 misalnya.
Yeah, that's a good point. In my practice, I do not see the what do you call like the good point of 6-0 to provide more strength. So it's nothing for tendon. So that's why I come with 5-0. For 10 years, I've never used 6-0, even for flexor tendon. Only use 5-0 as a running suture at the epitendinous repair site. Because I see that, 6-0 is nothing. It does not really provide more strength. And other idea is to put the repair site into inversion rather than putting it into eversion, just to reduce the chance for the adhesion. So with the 5-0, we could get better control rather than 6-0 to put, like some level of these arrayed fibers to be into a more proper inverted repair site. But 6-0 is just okay because many still uses 6-0. And also with the textbook, many of the textbook that we have read in the past always provide with the understanding that 6-0 is actually good for the epitendinous repair. But that is just my practice, my clinical experience, that I do not see that 6-0 would be good enough for me. Umu, how's Lombok? Huntal? All right. So we come to the last minute. It's completely 90 minutes for our meeting. And I thank everyone. I thank Eliza for providing the video, and also Prita to be my, confident, to make me confident because I have you as my partner to describe things if I do not get good explanation, because you are the one who were supposedly to be also ready with the presentations. Thank you very much, Prita. All right, semuanya terima kasih. Sampai ketemu minggu depan. Next week, we will have guests from China, an orthopedic surgeon who will share us with her experience, a lady surgeon, for next week. So Prita would be for the next 2 weeks. All right, so thank you very much, everyone. Have a good night.
Oke. Ya.
Good night. Thank
bye.
you. Bye.
Ya.
Thank you. See you
Thank
next week.
you.
Good night, Dr. Teddy. Thank
Dr.
you.
Teddy.
Thank you,
Yes.
everybody.